Today's lecture we will be talking about conjunctivitis. There is a QR code for this lecture. You can scan or send to download this lecture. There is the general evaluation and differential diagnosis of conjunctival inflammation. We'll be talking about the symptoms, what is the kind of discharge, the appearance of the conjunctiva, and development of pseudomembrane or membrane, and development of lymphadenopathy. Starting for symptoms, general symptoms for conjunctivitis including non-specific symptoms, which include lacrimation, irritation, stinging, and burning, and photophobia. There is also pain or foreign body sensation, which indicate corneal involvement. Also, itching is a hallmark for allergic conjunctivitis. We cannot get any allergic conjunctivitis without itching. The discharge, the kind of discharge, we can indicate what is the cause of this conjunctivitis. If we have a water discharge, it indicates any allergic or viral inflammation. Mucoid discharge in vernal keratoconjunctivitis, the seasonal allergy, and dry eye. Purulent conjunctivitis indicate bacterial infection. Mucopurulent in mild bacterial and chlamydial infection. And chlamydia infection, we'll be talking about this kind of infection because this chlamydia infection can cause trachoma, and trachoma is a specific entity of conjunctivitis. The appearance of conjunctivitis. The follicular conjunctivitis is a focal lymphoid nodule with accessory vascularization. It can be caused by viral, chlamydial, paranoid, oculoglandular syndrome, hypersensitivity, or specific topical medications. This is an image of follicular reaction. We can see here in the lower lid, we can hear the follicular reaction. Papillary conjunctivitis, we can see this papillary conjunctivitis reaction in allergy. It's a conjunctival epithelial hyperplasia with central vascular core and surrounded by edema and inflammatory cells, and there is a fibrous septa in between this papillae, and there is the image and this is the image of the papillary conjunctivitis. We can see here the inverted upper lid. We can see the cobblestone, and I think we will talk, or we already talked about the allergic conjunctivitis with this specific papillae. The appearance of conjunctivitis. Membranous conjunctivitis, it's an entity. Diphtheria bacilli is most common. It's the far most common organisms that can cause membranous conjunctivitis. Some viral infection can cause membranous conjunctivitis. Chemical burns, fungal infection, and severe pneumococci infection. There is a pseudomembrane. Any infection with sebaceous discharge can cause pseudomembrane. What's the difference between? There is some laboratory investigation. It can be done in a patient with conjunctivitis, in severe purulent conjunctivitis, in neonatal conjunctivitis, follicular conjunctivitis, inflammation with insufficient distinctive etiology. We can do either culture, impression cytology, PCR, or antigen detection. There is some entities or types of disease with conjunctivitis. If we have a conjunctivitis with inflammation of the eyelid, it's called peripheral conjunctivitis, combination of conjunctivitis and blepharitis. And if we have inflammation of the conjunctiva plus the cornea, it's called keratoconjunctivitis. And if we have also inflammation in the episcleral tissue, it's called episcleritis. There's a common question in oral and written exam. What's the differential diagnosis, or what is the difference between conjunctival and ciliary injection? Here's a conjunctival injection, inflammation of the superficial vessels. So the color of the conjunctival injection is more red. If we instilled a surface anesthesia in the surface of this patient, we can move these vessels because it's in the conjunctiva, not in the deep scleral vessels. And also, if we put a blanching agent like a phenylephrine, these vessels would constrict, and mostly this injection will go away. While in saline injection, we can see it's more deep red vessels. It's also circumscribing the limbus in the 4 millimeter outside the limbus. And also it's deep red, and also if we instilled a blanching agent, these vessels will not blanch because it's deep, and also we cannot move these vessels over the eye surface. Then we move to the acute bacterial conjunctivitis, either MPC or mucopurulent conjunctivitis, or PC or purulent conjunctivitis. The duration is less than 3 to 4 weeks. There is hyperemia and discharge. The commonest cause for this type is infection conjunctivitis. It's very common that for 80% of MPCs, it's from Haemophilus aegypticus, and we can indicate from this name that's very common in Egypt. Gonococci is responsible for 80% of purulent conjunctivitis. Other organisms include Staph aureus, Strep pneumoniae, Strep biogenes, and other organisms. What are the predisposing factors for this type of conjunctivitis? Bad hygiene, flies, dry eye, lid margin disease, what's called blepharitis, lacrimal passage obstruction, and conjunctival trauma. Again, from this previous slide, what are the symptoms? There's some discharge, thickness, itching and burning. There's also water discharge, foreign body sensation. The eyelid can be swollen. Because of the discharge, the patient can experience a colored halo in his vision. Usually it's bilateral, but can start unilaterally. Also, if it's severe, it can cause some fever, headache in purulent conjunctivitis. What are the signs? The lid are edematous and glued in the mucopurulent conjunctivitis, and there is a conjunctival injection and discharge. In the purulent conjunctivitis stage, is the stage of infiltration. There is more edema, more injection, subconjunctival hemorrhage, and lymphadenopathy. Planuria, there is a capricious discharge and edema, and the stage of coronacities is the stage of complications. There is some images of what is conjunctivitis, mucopurulent conjunctivitis. Here's indicate the hyperemia of the conjunctival tissue and some lid swelling. Then there is more redness of the eye. There is water discharge from the conjunctival infection. There is more edema and some chemosis in the eyelid. And here is the sticky discharge coming out of the eye. There is more conjunctival chemosis and more lid edema, and we can see the sticked together eyelashes. There is more discharge and sticking of the upper and lower eyelids. More and more discharge. What are the complications of purulent conjunctivitis? It can it can infect the cornea and causing some central and peripheral corneal ulcers, which are very serious. Also can go to chronicity stage, and if it spread systemically, it will cause gonococcal arthritis, endocarditis, and septicemia. What is the treatment? There is some prophylactic treatment and curative treatment. Prophylaxis means that you treat the source of infection and contacts and the other eye, and all the hygiene habits. For the curative treatment, we can use boric acid 3% to remove all discharge. There is local antibiotics. We can use any type of broad spectrum antibiotics. Also, we instruct the patient to take antibiotic ointment in the bedtime. We can use systemic antibiotics if it's systemic involvement. We can do lateral canthotomy, which is cutting of the edges of the eye, of the peripheral edges of the eyelids, if we have a very severe discharge and all the lid is swollen and we cannot take the discharge out of the eye. So we do lateral canthotomy in the extreme conditions, and we can use atropine. Atropine here, it's said that if we have a corneal involvement and infection or corneal ulcer, we have to use a cycloplegic agent. Ophthalmology is one of the most common topics that are asked in the oral and in the written exam. The definition, it's any infection in the neonates. The causative organism is 80% from Chlamydia oculogenitalis. Gonorrhea is responsible for the rest of 20%. Other bacterial hospital infection like staph and strep. There's some viral infection, which is herpes genitalis, and also we have an entity, it's called chemical keratoconjunctivitis. They used to use silver nitrate in the neonates to as an antibiotic, but then we saw many cases of what we call the sterile ophthalminotorum. But this silver nitrate is not used anymore. Most of the pediatric doctors now using antibiotic as in the neonates. What are the signs? There is some lipedema. There is a different type of discharge. Usually it's yellow and perfused. Also, we should remember that these neonates, they will not develop a follicle even in the virus. The herpes simplex, it takes more time. It's not in the first or 2 days. It will we will see it in next 2 weeks, and we can see a corneal infiltration. And also we can see some lymphadenopathy in the preocular and submandibular lymph nodes. What is the treatment? Again, we can start with prophylactic treatment with proper antenatal care, treatment of any maternal infection, antiseptic delivery, and broad spectrum and local eye lotion. The active treatment, we can start with hot fomentation and boric acid eye lotion to remove the discharge. If the chlamydia, we can use erythromycin. In gonococcal, we can use local penicillins. Cycloplegic is used if there is a corneal infiltration, and systemic and broad antibiotic also can be used. What is the complication of ophthalminotorum? Cornea can be affected and cause secondary corneal ulcer, and this corneal ulcer can be healed and cause dense corneal opacity, which cause amblyopia and defective vision, and the patient can be seen with nystagmus, which is a rapid movement of the eye. And if there is a unilateral from this dense corneal opacity, the patient, the baby will have squint. Also, it can be complicated by cataract, and also the infection can spread to the posterior of the eye and cause what we call endophthalmitis, and if it's spread outside even the eye to the orbit, it will cause panophthalmitis. What are the differential diagnoses? It's very important to differentiate between ophthalminotorum and congenital dacryocystitis. Congenital dacryocystitis, we can see a swelling over the lacrimal sac, and there is epiphora and positive discharge. Ophthalmos is very important to differentiate from the ophthalminotorum. There is a hazy and large cornea with high intraocular pressure, photophobia, and lacrimation. And also, they used to use forceps for delivery. The patient, we can see this kind of trauma from these forceps, but it's not common now because of less use of forceps for delivery. Pseudomembrane and Sorry, what's the difference between pseudomembrane and true membrane? The pseudomembrane, if we remove it can be easily removed from the surface of the conjunctiva, and it will leave a bleeding surface, while the true membrane, it's very difficult to remove this membrane from the conjunctiva. Then we move to some miscellaneous conjunctival disorders. It's not common and not commonly asked, but we have to know it. There's conjunctival concretion, which is a epithelial inclusion cyst filled with epithelial and keratin debris. This is a subconjunctival injection. It can start with a small dot of redness, and then it will increase in size and will take this triangular shape with the base of the triangle over the limbus and the apex over the periphery of the conjunctiva, and usually associated with trauma or any straining like severe coughing, sneezing, and constipation. Also, there's the zeros. I don't know if you can see well in this image, but I think the next image will be better. It's called beto spots. Here, the outline of the beto spot. Again, this is the beto spots, which indicate there is a dryness in this eye, and it's called xerosis. It's very common to see, and the treatment is tear substitute and vitamin A. Hello again. We will be talking today about follicular conjunctivitis. This is a QR code that you can scan and download this lecture. Follicular conjunctivitis, it's either acute or chronic. Acute follicular conjunctivitis, it's either also chlamydial or viral infection. Chronic follicular conjunctivitis is either trachoma, one of the most important topics that we'll be talking today. Also, using of atropine and pilocarpine eye drops can cause chronic follicular conjunctivitis. And there is a third entity called folliculosis. It happens in children in the lower fornix. It's also due to herpes or adenovirus infection. For the investigation, as usual, we can use the immunofluorescent staining, and we can get some specimen from the cervix or the urethra, and ELISA and GIMSA staining of the conjunctival by scraping on McCoy cell culture, and we can do also PCR. Okay, we're now talking about trachoma. It's called the Egyptian ophthalmia. Here is the range of distribution of trachoma. We can see it's usually seen in the developing countries. 1/5 of the population have been proven to be affected with this disease, and it's a major cause of blindness in the world. And it thought that the spread of trachoma happened with the wars in Napoleonic era, when Napoleon invaded the Middle Eastern and Mediterranean Sea countries. General topics is talking about trachoma. It's flourished in unhygienic and crowded surrounding. In endemic areas like here in Egypt, children are infected in first few years of life. It's contagious in its acute stages. It's spread by transfer of conjunctival secretion through fingers or towels. It's also spread by flies. And if there is a meticulous cleaning, it can prevent its spread. The chlamydia trachomatis organism, it's a typical virus. It has intracytoplasmic basophilic inclusion body, which is large with no solid immunity. And also they consider a gram-negative bacteria with rigid wall, sensitive to antibiotics, and it has RNA and DNA, and it has a property of binary fission, and also it has enzymes. Symptoms of trachoma, it can be minimal if uncomplicated case. When other infections supervene, it can be symptomatic. In chronic stage, considerable, there is an irritation, photophobia, lacrimation if the cornea is infected. and the sequelae, it depends on complication, and if there is atrichiasis, which is abnormal position of the eyelash, can cause complication. For the signs, there is a conjunctival signs. It's usually in the upper tarsal conjunctiva. The essential lesion in the trachoma is the trachomatous follicle. It can reach to 5 millimeter in diameter, usually in the upper fornix and upper palpebral conjunctiva. And trachomatous infiltration means spread deep into the subepithelial tissue of palpebral conjunctiva and even invade the tarsal plate. There is a minute satellite scars can be visible with slit lamp examination. For the cornea, it starts with superficial punctate keratitis, and then the infiltration can cause what called Herpet's follicles, and we can see here the Herpet's follicles. Here's we will be talking about the panas, and here's the Herpet's follicles after resolution, and it turned to be Herpet's pits. And it can cause panas, and if untreated or complicated, it can cause corneal ulcer. Trachomatous panas, it develops as a lymphoid infiltration with vascularization. There is three types of panas. There is a progressive panas, or sorry, there is three stages of panas. Progressive panas, where the vessels are mostly parallel to each others and directly vertical downwards, and smooth is little infiltration ahead of vascularization. So we can see the infiltrative cells ahead of the vascularization. And then regressive panas, where the vessels lie ahead of infiltration, so the vessels creeped over the infiltrative cells. It means that there is a resolution or regression of the panas. And then the healed panas, where the vessels are sclerosed and there is no infiltration. Usually, panas may resolve completely, leaving a clear cornea if treated early before destruction of the Bowen's membrane, and the follicles can be healed to cause the Herpet's pits. There's different types of panas. There's the panas tenuis, where is a thin panas, vasculosis, where is a vascular panas, annulosis, where is a rounded panas, carnosis with a fleshy panas, and siccus, which is the common type we can see in the healed corneal affection of trachoma. And we can see here the picture of the panas siccus. Sclerosed vessels, no infiltration, usually in the upper part of the cornea and the limbus. The investigation, as usual, we can use a microimmunofluorescence test, monoclonal antibody, McCoy cell culture, ELISA PCR, and histological demonstration of inclusion body for confirmation of diagnosis of trachoma. There is different classification. This disease is a very old disease, so McCallin have adopted a classification where he classified trachoma as 4 stages, with stage 1 incipient trachoma, stage 2 with established trachoma, stage 3 is cicatricial trachoma, and stage 4 is a healed trachoma. But now WHO had a new, relatively new classification. It's a FISTICO, where trachoma F is the first stage, where the follicle in the active disease is 5 or more follicles of at least 0.5 millimeters diameter on the upper tarsal conjunctiva. And if it goes to be intense, trachoma I is a severe disease with pronounced inflammation, thickening, which obscure more than half of the normal deep tarsal vessels. And trachoma S, where scarring, it's old inactive infection, tarsal conjunctiva scarring seen as white fibrous band. Trachoma T, where the trichiasis happens, and CO, which is corneal opacity, where there is a complication in the form of corneal opacity. This is one of the most important questions in the oral and written exam. What are the complications of trachoma? Complications of trachoma can be on the conjunctiva, on the cornea, on the eyelid, on the lacrimal system. It can include trachomastosis, entropium, trichitis, tylosis, pannus, corneal ulceration, corneal opacity, and dry eye. Here's some pictures. Here we can see the trichitis or entropium. Here is the trichitis, and here is entropium. Here is also entropium. Here's severe form of entropium. Other pictures, maybe it's not that obvious, but we can see the starting of corneal opacity, and here's the follicles, and here's the scarring of the tarsal conjunctiva or palpebral conjunctiva. That's Arlet's line. We can see scar over the palpebral conjunctiva. Here's the post-trachomatous degeneration, and here's post-trachomatous calcification. Here's another picture of the follicles, the PTDs or post-trachomatous degenerations, scarred palpebral conjunctiva, and the entropium. What is the treatment? Usually it's preventive or curative. We can use topical treatment, tetracycline, erythromycin, and there is also some trachoma control programs. Systemic, we can use oral tetracycline or erythromycin or doxycycline. Usually it's a single dose of azithromycin of 1 gram. Treatment of complication, usually pannus require no special treatment. Corneal ulcer we can treat as a corneal ulcer. Trichitis, either a dilation or electrolysis. Entropium, it can be surgically corrected. What is the most common cause of scarred palpebral conjunctiva? The most common is trachoma. Other causes include trachoma, membranous conjunctivitis, chemical injury, and the Stevens-Johnson syndrome. There is 2 complications: cicatricial entropium, trichitis, xerosis, and the posterior symplectrum. The identity of posterior symplectrum, where there is adhesion between the palpebral and palpebral conjunctiva. It can be caused by healed trachoma, chemical burns, membranous conjunctivitis, post-operative after pterygium surgery. Usually when the patient try to look in any side, there's a restriction of movement which can cause a binocular diplopia. He can see double vision, and there's some symptoms of lack of thalamus, because sometimes it cannot close the whole palpebral fissure, and also there's a cosmetic disfigurement. Treatment, first you should treat manage the lack of thalamus. We can excise the fibrous tissue with glass rod or artificial conjunctival shell. We can use mucous membrane or amniotic membrane graft, and also we should not forget the treatment of the cause. Thank you very much. Again, there's a QR code that you can scan and download this lecture.